Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is brought to you by Axome.
Today's episode is live from Sleep Medicine Disruptors in Austin, Texas. We have had 2 days of aspirational keynote speakers and some really fun Shark Tank-like pitches for new innovations in sleep. So we've chosen a couple to chat with today. I think all the pitches have been really excellent. You know, as Azizi said, they really honed them down from, I think, 12 or 15 or something people. So we picked 2. And this was the ones that we thought really appeared to capture the idea of innovation in sleep. So please help me welcome Dr. Jason McKeown from Neurovalens and Dr. Onur Kilic from Bairitone. Come on up. So Dr. McKeown is a neurologist who has, of course, created a non-pharmacological treatment for insomnia using vestibular nerve stimulation. And Dr. Kilic has created a sensor that allows for a non-invasive airway assessment of upper airway collapsibility, which really may help us personalize obstructive sleep apnea treatment. Well, thank you guys. Who wants to go first? Jason, should we start with you?
Yeah, go ahead.
So for anyone who knows me, I am a little bit neurotic, a little bit detail-oriented. So we chatted a week or 2 ago, something like that, just so that I could learn what you do a little bit better. And then, of course, I created some questions, and they never go in order. So I wonder if you can give us just like a 60-second recapitulation of your pitch.
Perfect. Yeah, no, thanks for having us on the podcast. So Jason McKeown, CEO of Neurovalens, UK-based medical device company, very small kind of startup company. But we've made technology that allows us to turn on neurons in sort of autonomic nuclei in the very center of the brain. So we've sort of multiple, I suppose, pipeline with multiple approvals already. But our big focus right now is the Modius sleep device, which stimulates the brain before you go to bed and does 2 things. Essentially, transitions the brain from the waking state to a sleeping state, so it helps you fall asleep faster and stay asleep longer. But then importantly, the daily use at the same time before you go to bed causes circadian entrainment. And last year, that device got FDA-cleared as a treatment for adults with chronic insomnia.
So I think one of the things I've grown to appreciate over the years is that every new innovation, every new treatment that we see starts with a story. So what is the story? How did you come up with this?
So I think I've never met a doctor or a prescriber who wants to prescribe more sleeping pills or sedatives. Correct me if I'm wrong. And you know, certainly I was in that boat. So whenever I was treating my own patients, I'd say, to be honest, I just got really frustrated that I didn't have great treatment options. And it's difficult, and we've all experienced this. Patients come in with their family, they're really desperate. There are 4 or 5 people in the room wanting you to do something, and they're really reaching out. And sometimes you feel, I just have to do something for this patient. And if the only option is sleeping pills or sedatives, it doesn't feel like the right choice, particularly maybe when it's an elderly patient and you know you're thinking, yes, this might sedate them, but if they get up and they're confused during the night and they fall, and there's just a whole host of negative consequences. So my on and on frustration with this just led me to look at, well, why don't we actually use some other modality to target the area in the brain? And then, kind of long story short, there was we started looking at old kind of NASA data, looking at how the mechanisms of the inner ear. And we presented all this to a lab at UC San Diego, and essentially they said, we love the idea, come and develop this technology and see if you can actually work this right through to FDA approvals. So it all started basically going right back to when I was just being frustrated with the fact that I couldn't prescribe anything other than sleeping pills.
So, but help me understand this, because I feel like I've seen something similar on like social media. This like thing that you wear around your neck and it stimulates vagus nerve, maybe?
Mm-hmm. Yeah, I suppose the getting into the center of the brain is difficult. So, you know, back when we were doing surgery, you're literally drilling a hole in the patient's head. You're putting a probe right down in. So you can think of how extreme that is. But what we would have looked at is, well, how about we use almost, I call them wires that are already there, but essentially your cranial nerves. Your cranial nerves act like a wire. They go right in through to the brainstem, and they project up into cortical areas. But for a long, long time, the focus has been on the vagus nerve. And I think actually it's more so because the vagus nerve almost like connects to everywhere in your body. So it's like, hey, if we stimulate this, something's bound to happen. But I'm a little skeptical of that approach. Actually, we started looking at, well, what actually is the purpose or the mechanism of some of the receptors at the ends of these cranial nerves? So you got your trigeminal nerve, your face, you've nerves all over. But very quickly we got interested in the vestibular nerve, particularly because the gravity receptor in the inner ear actually has a direct connection. And I mentioned this in my talk. It's called the vestibulo-hypothalamic pathway. But that is actually the pathway that is activated when you rock a baby. And it's why kids in the back of the car fall asleep. So you're activating that pathway. So our technology is extremely specific. If it doesn't activate that receptor, it won't work. So devices which kind of electrify the whole head, like some would clip onto your earlobes, or you can stick kind of devices on your prefrontal cortex, and you can do vagus nerve stimulators. They may well work. I am not criticizing those devices, but the mechanisms behind that is quite general. We're just going to stimulate it, whereas ours is very different and very specific in that we activate the single receptor to then activate these neurons in the center of the brain.
Okay, but I have to tell you that the more I hear you talk about stimulating the vestibular nerve and the rocking, I'm like, ooh, I'm getting a little car sick. So is that a side effect?
So theoretically, and it was something we were quite worried about whenever we started designing the clinical trials, and actually the low frequency and the motor sleep device is a very low frequency. There is actually a correlation with very low frequency rocking, and that can give you that nausea feeling. But what we actually did was we designed the device to be, I suppose, titrated by the patient. So initially we thought we're going to turn it on, it's going to have a fixed current, but actually some people are so sensitive that they actually get this real sense of sway because you're activating the vestibular system. And then some people are the opposite, they don't feel anything. So we actually designed the device to have 10 different stimulation levels, and the patients just increase. And that does two things really. One, it allows them to be comfortable, so it's always delivering a stimulation level they're comfortable with. But the other thing that happens, and we've seen this across our clinical trials and across all of the real world data, patients actually almost instinctively know the threshold before which they will actually experience that feeling. So in all our trials, we were expecting cases of kind of nausea or even like a vertigo type side effect, but actually we don't see it at all because patients know to stop beforehand. So that titration method is actually probably one of the best features we have on the device.
Is it really? So I feel like, is this similar? I bought something years ago. I want to say like a Wallace Fisher for maybe anxiety. I bought it for one of my kiddos. Is this similar to that? I think she wore it on her head.
So I mentioned again in the talk earlier, so 2019, the FDA updated the guidance, and essentially any device that applies electricity kind of to the head or the cranial nerves, it falls under that kind of similar regulation. So we know that technology is safe. But the Fisher-Wallace device, and there's another one, or AlphaStim, there's CS Ultra, there's a range of those devices. Those all fall under the old regulations for the FDA. And Neurovalens is the only company that has actually approval under these new regulations that we had to provide our own clinical data. Now, strictly speaking, those devices now have to go back to the FDA and present clinical data. So it'll be interesting to see just what happens over the next few years, because if they can't present clinical data, they actually will have to stop marketing. And if you look, a lot of those devices actually had approval years ago for insomnia, anxiety, and depression. All of those devices, if you look, have taken depression off their indication.
Oh, they did?
Yeah.
Oh, that's interesting.
So some of them still say insomnia, anxiety. Some of them have quietly disappeared. But as I say, it's just these new strict regulations. I suppose to summarize what I'm trying to say is, it was a little easier to get approval years ago because you could just do a 510K and kind of say, this device is the same as this device. I don't need any more clinical data. Whereas now you can no longer do that. You must present the clinical data. And as I say, we're the only company who has done that so far.
So I didn't realize the FDA worked like that. That I thought you would be grandfathered in. Like you had an indication and that was it.
Up until 2019, that was exactly the case, yeah.
Ah, okay. So if I'm trying to do this in clinic, who am I not able to do this with?
I think the two common maybe contraindications that would catch people out was pregnancy is one. Not that we have concerns, just the FDA just want us to put a pregnancy on the label because we don't test in that group. But interestingly, the FDA also have a contraindication, which is implanted neurostimulators. And that's really any implanted neurostimulators. So a cardiac pacemaker is a contraindication, a cochlear implant is a contraindication, DBS, VNS, but even the Inspire device.
I wondered about Inspire.
Yeah, so we did.
So even though you use Inspire, not at the same time.
Yeah, this is a conversation we've had with the FDA quite recently, actually. I actually, a couple of weeks ago, went to meet them, and this was the point of kind of contention. It's like, if you look at the Inspire device, it's not active whenever our device is being used. So it's used before, our device used before you go to bed. And if you read their contraindications, we're not on their contraindications. But somehow they are on our contraindications, and it's just a slightly strange scenario. So we're working with the FDA to potentially remove that. But what I do know is a lot of physicians are just pretty comfortable prescribing it because they know the two devices aren't on at the same time.
Yeah, because I kind of wonder if it would help with sort of desensitization, right? COMISA is a huge problem, and I'm not sure that we have a really robust solution that people are willing to do, right? We have lots of data on CBT-I, but I think for me anyway, that it's such a tough conversation to get buy-in from patients.
Yeah, we've actually started a project in COMISA really with a well-known sleep apnea company. And essentially we're looking for two things. One would be, can we just get better ISI? So use our device and then use CPAP. And then in the morning, what's your ISI? Or over the next weeks and months, what's your ISI? That is kind of the big outcome we're looking for. But a secondary one is actually, would you get better compliance with CPAP? So if we can put you into a slightly deeper sleep just with our device before you go to bed, will that make compliance higher with CPAP? And even that in itself would be a great outcome. So yeah, that's a real hot area of interest for us.
I'm really disappointed about the pregnancy.
Yeah, I think this could be potentially really a great way to treat insomnia, but the other sort of neurological issues that we look at in pregnancy, because it's such a safe and targeted device. There's no systemic electricity flowing through. We turn on a receptor and it fires neurons in the very center of your brain. So potentially something we might look at down the line, because it would be really nice to offer pregnant women something that's super safe but will actually treat their insomnia.
And so how is it if we want to get our hands on this? What is the process? I'm assuming prescription.
Yes, yeah. So all our devices are prescribed. So essentially, if we get a prescription, we can either ship direct to the patient, or if physicians want to have it in their clinic, they can sort of resell to the patient. Our kind of phase 1 push was through the VA. So anyone on the VA, it's fully reimbursed. We just need a prescription come through the VA system, and we will ship it to the patient's house. And then kind of we're calling it phase 2. Then as we're trying to move into that more reimbursed insurance space, and that'll hopefully be sort of rolling out early next year.
Yeah, that's what after we visited, I actually spoke to a couple of patients, and so we were trying to figure out how to get it, logistically, right? The order. So do you think, you said physician offices, but do you think it'll also live at DME, or it'll be directly from your company?
I think we'd be interested in all of the above. So the kit that we supply currently is DME. So yeah, our goal is really, we just want this to be accessible. We don't want patients to have to think about, oh, I can't afford it, or how much does it cost? We just want insurance to cover it. But as everybody knows, it's a long process. So as I say, hopefully the first stages of that will be early in 2026.
So any other final thoughts for us with your device? I usually will share with our guests, this is your platform. This is an ASM space, right? We are all members. This is your platform to speak to our sleep medicine colleagues. Is there anything else that you would like them to know?
I just highlight again, as prescribers, you should have confidence in this technology. So you're bound to see patients across that spectrum of first presentation of insomnia. When I see patients with first presentation, the last thing I want to do is give that patient a drug, because it may be that they are on that drug for a long, long time. But the opposite is true at the other end of the spectrum. If these are really difficult patients who have tried loads of drugs, or maybe are on polypharmacy already, the last thing I want to do is give that patient another sleeping tablet. So we've created something that is backed up by really robust, sham-controlled clinical trials. It is super clear that this device treats insomnia. So right across your range of patients, we just want people to, first of all, know about the device, know it's available, but be confident that you can prescribe this, and this is genuinely making a difference to people who suffer from insomnia.
Very cool. I am very excited to learn more and to try it with some of my patients. I'll let you know.
Absolutely. Yeah.
Jason, you've given us a lot to think about. Let's take a short break, and when we come back, we'll talk with our next guest at Sleep Medicine Disruptors. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Onur Kilic about his new sensor, which may allow us to obtain anatomical information about airway collapse.
So, Onur, your turn. So you won yesterday. Congratulations.
Thank you.
It was very exciting. So can you remind us 60 seconds about your device?
Yeah, so the care pathway for obstructive sleep apnea used to be very simple. You would get a sleep study, and if you had sleep apnea, you would get a CPAP. And if CPAP didn't work for some reason, well, tough luck. There weren't really many effective options available there. So in response, people came up with different solutions, different treatment modalities, from nerve stimulators or appliances to improved surgical procedures and many more. And while CPAP acts as a pneumatic stand on the whole upper airway, these treatments are more targeted, and they're only effective if matched to the obstruction behavior of the patient. So we developed an anatomic polysomnogram that provides the obstruction profile during a sleep study, so that we can then match these patients to the right treatments.
And it goes on the cheek, right? It's like a patch?
Yes, it goes on the cheek.
And it uses sonar?
Yes, so I can talk a little bit about that. So it's a good question, but I want to talk about fish now, salmon specifically. So king salmon, Chinook, is the favorite food of killer whales, and they are able to track it so well that even if they're in a school of 100 fish, if there's a single king salmon, a Chinook, an orca a killer whale can identify it, even when the other fish are similar sized salmons, such as sockeye or coho salmons. And it turns out they're able to do that because the swim bladder, which is a little organ in salmons, the anatomy is a little different than other salmons, other fish. And orca are able to do this from a distance, identify anatomical differences in the swim bladder, and able to dynamically track in a complex environment the king salmon. So we were inspired by this. So we thought, why can't we do it? Let's use sonar principles so that we can, from a distance, track changes in the anatomy at distal places, and use basically same principles that killer whales use.
And so it allows you, because of that signature, to figure out what the level of collapse is?
Yes, exactly. So vibrations travel really well in tissue. So when there's a source of vibration, such as the uvula, which is often the case, these vibrations travel through bone, soft tissue, everywhere, and are able to probe the whole anatomy. So our technology is able to identify changes in this travel signature. So any anatomical change will introduce changes in these travel paths, and that way we are able to track several things regarding anatomy. First of all, it gives you a comprehensive picture at all levels of interest, from the velum down to the epiglottis. We are also able to track the degree of obstruction, because that also introduces a change in the signature, but also more challenging, the configuration, the shape of the obstruction.
So is the obstruction static, or is it dynamic? Does it change over time? Like if you have this person and you do this and you're like, yep, this is at the level of the velum, in a year, is that still going to be true?
So good question. Dynamic at every level. It's dynamic at every level. Even when you look at a single event, we can see actually changes between breathing in and breathing out. But also throughout the night in a single patient, there are lots of changes. And we have seen in a patient that we were gathering data from, where similar anatomies throughout the night cause different effects, where the beginning of the night it was causing more desaturations, but towards end of the night, similar anatomical obstructions were causing more arousals. And that also points to the fact that anatomy by itself is not very meaningful unless you couple it to sleep context. So if you look at it in the context of sleep, how it changes between sleep positions, sleep stages, and other sleep metrics, then you get a better picture to make better treatment decisions. And one of the most important things, I think, coupling anatomy to sleep context is being able to identify what's a primary obstruction versus a secondary obstruction.
Okay, tell me about that. What do you mean by that?
Okay, so a primary obstruction I would define as something that's a consequence of a functional or pathobiological mechanism. So an endotype, the phenotypic expression of an endotype. If you think of dominoes, it's the first domino that is pushed by somebody that falls.
Okay.
Secondary collapse is as consequence of the primary collapse. So it happens only because of the primary collapse. Just as an example, the tongue falling back, pulling the velum with it, or pushing the epiglottis or an oropharyngeal wall collapsing laterally and causing lateral collapse in the epiglottis. And that would be like the second or third or etc. dominoes.
So then so when you're trying to figure out what treatment that you would address the primary collapse, or does the secondary collapse have some meaningfulness?
So you want to address a primary collapse. So once you address the primary collapse, you'll address the issue. There won't be secondary collapses. But the problem with secondary collapses is if you don't know if there are secondary collapses, then it will affect your treatment decisions. You might see, like in my talk yesterday, I was showing an example where you have severe collapse in the oropharyngeal walls and tongue base, which were secondary. At surgeons seeing this might think of multi-level surgery or some other combination therapy targeting those specific regions. But if they know that they're secondary collapse, then they won't bother. They will just target the first collapse, which in that example was a partial obstruction in the velum that was causing a flow limitation, and with the increasing respiratory effort was leading to increasing negative pressure downstream that were leading to this secondary collapse.
And you can tell that by the data you collect?
Yes.
Okay, so I have to say, you know what I love about this is that you have come to our field from a completely different background. Tell us about your background.
Okay, all that killer whale stuff is a fascination from my times when I was working on sonar technology. So I was at Stanford developing defense technologies, things like how do you detect silent submarines with next generation sonars. And it went well. We had like 70 patents that were mostly licensed by defense defense industry. But I had a change of heart, switched to the medical field, went to the Johns Hopkins Medical School, did research there in various different fields. One of the fields was cancer. So I ended up starting a company with people from the Mayo Clinic and Yale that was developing drugs and companion diagnostics for brain cancer. And after COVID hit, I moved to Houston to be with my family and met my co-founders, and we thought, this is a good opportunity to be in sleep because there seems to be lots of activity on the therapy side, a booming therapy space, and there seems to be some disconnect with the diagnostic space. And we thought, why don't we try to bring these together by solving this issue that we thought of.
So you're trying to kind of personalize treatment based on anatomical parameters.
Yes, exactly. And that's only part of the question. So initially we thought that's the main issue, identifying patients that would benefit most, like from a given therapy, that all these new therapies coming to the market. But the more we talk to these therapy companies, we realize that's just, let's say, 30% of the problem. A lot of companies also, these new technologies have issues with titration, and they want to do it in a steep lab, sometimes in real time, to make sure that their new therapies work. And it's actually challenging. It's sometimes a big problem for them to properly scale their technology, because if they have to spend a lot of time for each patient, then it's an issue. And the third one that we a lot of get questions about is there will be changes in the response. Sometimes responses vary or treatments fail. How can we understand it better? And this is a concern from nerve stimulators to even like surgeries, for example. You want to know if the surgery is successful in 6 months, in 2 years, can you see if there is certain remodeling that changes the success rate, and how we can address this?
So this is something you can do at home and in the lab, right?
Yes. So we want it to be used in the lab because you get more contextual information. There's a lot more information about sleep you can get in the lab. But we see how, from a scaling point of view, that it's also good to have it at home. And we have now home-based PSGs like Nox or Onera and many others that are coming to market. So you'll be able to get lots of interesting, good level of information from home-based sleep studies as well. So we are currently building a more user-friendly, more compact device that we hope we can send to home so that we can gather gather anatomical data alongside home sleep tests.
So you taught me something last week that I didn't realize. And you said that a lot of otolaryngologists don't like to do DICE, which I had never considered. Why is that?
Well, a lot of surgeons want to do surgeries, and they don't like spending valuable OR time. Hospitals don't want to, use OR for DICE, and DICE isn't well reimbursed.
It's not well reimbursed. Oh, okay.
It's not well reimbursed. So hospitals spend more time. They lose money on doing DICE. They just earn money after, something like Inspire is approved. That's part of the question. The other problem is anesthesiologists really hate it because you have to sedate the patient to a point where they start to suffocate for DICE to work, and that's not something people like as well. So anesthesiologists don't like it, surgeons don't like it, hospitals don't like it, and I assume payers don't like it either. And I can't imagine any patient that likes it either.
Well, and so it's funny because one of our colleagues, and so I'm a pulmonologist, and one of our colleagues just put something out teaching pulmonologists how to do DICE, which I don't know why it has never occurred to me in all of these years that I'm like, well, I could be doing this too. Not even once. And then one of our colleagues here mentioned that dentists are doing DICE as well. And so I think if the OR is worried about DICE, it makes me nervous about dentists doing DICE as well, but maybe they do it differently.
Well, I know I probably have strong opinions about this. I think sedation in the US is especially overdone. I think people underestimate what a major perturbation on the brain homeostasis sedation can be. I mean, it's okay for healthy brains. Healthy brains have strong homeostatic mechanisms that can bring it back. But if you do sedation on a compromised brain, then I have seen people coming out of sedation who are never the same. So I think sedation shouldn't be first to go choice. I understand that DICE is necessary right now, that there is no alternative, so we want to change that so that we can gather similar data, even better data during actual natural sleep.
Yeah, no, that's fair. And so this sounds like it's sort of a scalable DICE?
Sort of, but there are several problems associated with DICE. So one is the scalability issue. You can't really scale it. You can't bring it to many people. Second one is sedation. It's not real sleep. And
I wondered about that, yeah.
Yeah, and for example, DICE overestimates palatal collapse when they compare palatal collapse during DICE versus sleep, natural sleep in the same patients. It turns out more palatal obstruction events happening during DICE. So there are lots of issues associated with that. I think the bigger issue with DICE is it's a crude way of assessing the anatomy. You just look at 4 different levels. You just score the obstruction with 3 different degrees, 0, 1, 2, like corresponding to partial, minimal, and severe obstruction. And it's very subjective. We never have very good agreement between 2 different surgeons, expert surgeons, looking at the same DICE videos.
But there's clearly a need. Like before DICE, people would do the Mueller maneuver, that you put the scope down, you have them inspired, you kind of look for the level of collapse. Because I think there's always sort of, is it comfort in maybe understanding the anatomy better, kind of understanding the why? behind sleep apnea? And I think that kind of leads into, is there a mechanism where you can predict someone who's going to be a good responder, right? And I think maybe that's what you're hoping.
Yes. So the first go-to implementation for us is trying to imitate DICE, because that's what surgeons or many providers are comfortable with. They want to see something that they can understand. Oh, it's a collapse in the velum, it's a collapse here. But I think there is a lot of more value to go into more nuanced anatomical biomarkers. So with the technology we are developing, with the type of data we collect, there's a lot more nuance. We see it in the when you look at this latent space that the model generates, so that we can visualize the data. You see a lot more nuance than these crude labels that surgeons use. And eventually, I think we'll be able to use these biomarkers to predicting outcomes. That's one of the grants we have submitted to NIH. It's right now on hold because of the whole government shutdown. But we hope if we get that, what we'll do is we are going to try to match outcomes from directly sleep measurements without trying to match them into these DICE-like labels.
Oh, interesting.
Basically develop our own anatomical biomarkers and trying to see how well we can predict outcomes specifically for Inspire, because that's a more standardized workflow where they implant Inspire and 3 months post-activation do an outcome sleep study. So it's easy data to get so that we can compare if we can predict it.
So one of our colleagues is an otolaryngologist and a sleep doctor, Raj Dedhia, and he talked about different ways that he can predict who will respond to Inspire. And he kind of talked about low CPAP settings, right? He talked about, and I think these metrics sort of hint at less collapsibility in the airway. And so what I'm wondering is, if somebody is going to have sort of a less collapsible upper airway, shouldn't they be responders to most modalities? Or like, what would make you, based on what you understand from the anatomic PSG, what would make you say, you know what, we don't think they're going to respond to an oral appliance, but yes, we think they're going to respond to Inspire?
So good question. So we don't want to give that level of advice to providers, because that
you don't. Okay.
Because FDA would have an issue with it. It wouldn't be easy to prove that you can comfortably give that level of advice to experts. But we also, don't want the providers to be the decision point. So the type of information we give is, this is the problem. This is the problem site, and once they know it, once they know if the velum, for example, is the issue, or if the tongue base is the issue, then I think they'll have the clarity to make more informed decisions. So
you're just sort of providing additional information about the level of collapse in that moment. You kind of talked about how it varies through the night. So then do you say at the beginning of the night, it's over here, and then over at the end of the night, it's over here? Is that what the report looks like?
Yes. Yeah. So we provide anatomic changes between different sleep metrics, like sleeping position, sleep stage. You could see, for example, from the data that certain the anatomical issues that cause obstructive sleep apnea are related mostly due to gravity effects in the supine position. And from that data, you might be able to see, or you could see, it's mostly happening during REM sleep, and think about treatments based on that.
So you kind of talked about the arousability, right? Like that arousal index was higher. And what I'm kind of wondering, if Jason's device, you do your thing before bed, I wonder if that would affect that arousability.
I think there's a potential collaboration in the making here. Yeah, happy to look at that for sure.
Right, because I think that sometimes there's more overlap than we maybe, I think for us as clinicians, sometimes it's easy to split it into buckets, right? Like, oh, this one has insomnia, this one has whatever, and that's just not reality, right? Whether it's COMISA, whether it's anxiety about CPAP, whether it's, a host of things. You wonder if maybe is multimodality therapy reasonable?
Yeah. Oh, absolutely. Just one of the interesting kind of projects we're looking at, it's not exactly the same, but it's related, is we were approached by a group of patients, or PTSD physicians, but specifically looking at those who had sleep apnea, and they wanted to see if there was a subtype where actually if they could put them into a deeper sleep, that they would then almost get through where they normally would waken, and actually the muscles in the neck actually would then start to improve the airway, whereas they were almost saying the chance, they'd never get the chance for that to happen because they were waking it up beforehand. And apparently this is prevalent in PTSD. So we were asked if we could essentially give our device to those patients to see if we can get them into a deeper sleep so they do not waken up, and then allows the time for the muscles to kind of open the airway.
Yeah.
So yeah, I think there's just so much overlap that actually you think maybe, oh, it's insomnia or it's OSA or whatever, but no, these things really are connected. So yeah, we're very interested in sort of looking deeper into that.
So are there other things up your sleeve that you are free to talk about with your device?
Yeah, sure. So our first, it was a 510K clearance as our insomnia device, as I say, with clinical data. So not like a traditional 510K, but we actually had the second approval, which is for anxiety. And it's the same, it needed clinical data. So we're actually getting that published now. I'm hopefully launching that later, but it's essentially the same patient experience. You put it on 30 minutes a day, usually in the evening before you go to bed. But the stimulation profile is very different. So we can activate slightly different parts of the brain. And then about 2 weeks ago, and I can't talk about this one, we actually got our third, it was a de novo approval. That's for totally unrelated disease space. But then probably our most exciting one is hopefully our fourth approval early next year will be for PTSD. So that's with the FDA right now. And those results are just phenomenal. So we saw this expected reduction in insomnia, really significant reduction, but we also saw independently a really, really meaningful reduction in PTSD. And for those who are interested in PTSD, we are the target. The target we agreed with the FDA was a reduction in PCL5. So a 10-point reduction was essentially what we were trying to get for approval. And we actually got a 23-point reduction. So the impact on PTSD is incredible, actually. And we think that that's probably going to be our really big device, hopefully sometime early next year.
Well, and I think that you've identified a subset of people who have sleep apnea that sometimes have difficulty tolerating PAP therapy, right? And so that is very interesting. And then you pair it with, oh, hey, you know what? Maybe, this is your level of collapse. Maybe this is an appropriate treatment modality for you. Yeah.
Yeah. We were talking to an ENT who was doing DICE with CPAP, actually, to see how certain CPAP settings affect anatomy.
Yeah.
And she was telling us about some patients where the tongue is so, the obstruction is so high, at a high level, where no matter how much you increase the pressure level on the CPAP, even at the maximum pressure level, the tongue obstruction wouldn't go away. So there are some cases where anatomy plays an important role in determining CPAP tolerance. And another example is, for example, the trapdoor epiglottal phenomenon, where increasing the pressure actually makes the epiglottis collapse even stronger. And those patients are also not good candidates for CPAP. And you can't really get this insight if you don't have access to anatomical information.
Yeah, I mean, that's fair, right? And I wonder if that's how hybrid therapy works, where you have CPAP plus a mandibular advancement device or something like that, because maybe they just need a little bit more opening for the pressure to kind of do its thing.
Yeah. And I agree with Dr. White, and several speakers mentioned it as well, where they were talking about combination therapy in the form of a mainline treatment plus something that's targeting more upstream mechanisms like endotype targeting drugs. There's obviously apnea drug coming in, so there's value in doing that kind of approach. So we have these mainline treatments that basically target the obstruction itself. So anatomy is very relevant there, but they are not always 100% effective. So therefore, there's value in also targeting more upstream processes that lead to this obstruction. And that's the way things are done in other fields such as cancer. For a long time, mainline treatments in oncology, surgery, chemotherapy, radio, etc., that were targeting certain phenotypes such as rapid proliferation, metastasis, angiogenesis, etc. And over time, people have come up with solutions that would target the endotype of cancer, the mechanisms that lead to these phenotypic expressions, such as, point mutations, hypomethylating agents targeting epigenetic rewiring, etc. And that's how we start to see a lot more success in cancer therapy as well. And I think we can adopt that thinking into sleep apnea, that kind of combination therapy.
It's so funny you say that. I remember years and years ago, I'd read an article about shift work being of the whole thing about breast cancer, and shift work is bad. And then there's some data on melatonin. And I reached out to a researcher who did melatonin research. And I was like, oh, you know what? We think sleep's really important in cancer. And she literally was like, yeah, we consider it a carcinogen. We're way ahead of you. And so I just love the idea that we can lean on our colleagues. We can learn from our colleagues. I think we've always been criticized for sleep being really siloed, right? You have to go to a lab and you have to go to a sleep clinic, and really sleep spills into everything.
Yeah.
And so to your point, we need to learn from our oncology colleagues.
Yeah, I feel like sleep apnea today is where oncology was a couple decades ago. Rich in mechanistic insight, rapidly expanding therapy space, but constrained by diagnostic tools that don't fully capture what matters for treatment. And that's basically why we are working on this technology. We want to bridge that gap and do what oncology has done a couple decades ago.
And I would argue probably what matters to patients, because I think, we have this idea of what matters to clinicians, and I think the FDA years ago started listening to the patient voice. And so they had done something with hypersomnias, and they asked a bunch of physicians, well, what do you want out of the stimulant? What is your endpoint? Of course, the physicians are like, well, we want improvement in MWT. We want improvement in MSLT. And when you ask the patient group, they said brain fog. And that wasn't on anybody's radar. And so I think that patient voice, that collaboration, right, is really important. And I think that what both of you are doing is allowing, some options. We're giving more data. We're giving more, ways of addressing it mechanistically, right, with the vestibular nerve. And so that gives me hope. It makes me, I've always been sort of a glasses half full kind of girl anyway. So I kind of love what y'all are doing. I have a question about the vestibular nerve. Are you allowed to keep stimulating it? Does anything happen if you keep doing that?
Well, all our devices would be designed to turn off after 30 minutes.
Okay.
So let's say, as I mentioned, there is actually, you get a kind of relaxed, sleepy feeling when you wear the device. So a lot of our patients just fall asleep when they're sitting there watching television. So we designed it to basically turn off.
Okay.
So there would be no issue with the patient falling asleep. But actually, even if you look at sort of long-term usage, so we have followed some of our original patients up for almost 5 years. And these are patients who were using trial devices almost every day for 5 years, which is kind of insane. And yeah, there's no, sort of long-term effects or any sort of concerns that we have with that. So that's why, and this is our big kind of selling point, particularly to the FDA, but now to clinicians and to patients. The safety profile of this is fantastic, and particularly if you compare that to, say, sleeping pills or sedatives. But then on top of that, we're getting these really nice efficacy outcomes as well.
So it doesn't wear out? You don't have to...
Yeah, that's actually a really interesting question. So the stimulation, if you turn it on for the very first maybe couple of sessions, you do feel the tingling in the skin, and it's just like a little sort of tingling. And as I say, you feel that vestibular sway. Patients accommodate to that a little bit. So after a while, they slowly keep increasing the stimulation level. So patients might start at level 1 or level 2, but by like a week or 10 days, they'll be up to, say, level 8 or 9.
Oh, wow.
But there's no accommodation to the efficacy. That doesn't actually drop off.
It doesn't.
No, so even if you follow these patients out for a long time and they're using at a high level or even a low level, the efficacy is actually maintained.
Wow, that is amazing. I have to say, Azizi, kudos. This has been just a phenomenal conference. We have to wait 2 years between every time he does it. I know you give me a lot of credit, but honestly, it's Steve Van Hout is the one that came up with it. I was just the guinea pig. And so, no, any final thoughts for us?
I could continue talking about killer whales, but no, it's been great. Thank you, everybody.
How about you? Final thoughts?
Yeah, I just love coming to conferences like this and really seeing the innovation and, and actually, putting patients first. I always hear of a mindset of what new things could I be given to my patients that actually will make their lives better and really impact them in a meaningful way. So yeah, no, I think this is fantastic. And thanks to everyone for having us here.
Yeah, thank you both for joining us today and really teaching us about some really innovative devices that I'm sure we're all going to see more in our clinical practice.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.